I think everybody knows Jeremy, but just as a way of formal introduction, he is a clinical social professor in the Division of Peds Gastro here, joined here at CHEAR. He earned his MD from the University of South Florida College of Medicine, trained in pediatrics at Boston City Hospital and Boston Medical Center, practiced general pediatrics in New York for several years before moving here to train in AIDS GI at UM. He then trained in HSR through the RWJ Master's Program at UM, and in advanced improvement methods at Cincinnati Children's. Joined the pediatric GI faculty here. His clinical and research interest is in the care of children and adolescents with Crohn and also colitis, also bowel disease. His research focuses on developing strategies to individualize patient care to improve short and long-term outcomes and improve health-related quality of life. He's been working on efforts to develop strategies to prevent disease-related complications such as fistulas and fasciitis and to mitigate disparities among children with IBD. He's an NIH-funded researcher whose scientific research has been featured in the American Gastroenterology Association's headline news and in the Innovation Healthcare section of the Wall Street Journal. Wow, he's the director of the Pediatric Inflammatory Bowel Disease Program here at UM.
Okay. Thank you. So that was everything. I have nothing else to say. Thank you. Thanks for coming. I'm going to talk, as Kawa said, about inflammatory bowel disease and improving outcomes. I'm going to focus on Crohn's disease because that's where we've been focusing our efforts lately. And some of you have already seen before. Hopefully there's some new information, but I thought I would actually go back further in time and give a little more background, which might put things in context. So I'm going to talk about complications, if we can predict prognosis and improving outcomes. So inflammatory bowel disease broadly, which is not the same thing as irritable bowel syndrome, and we can talk about that later if we want, but inflammatory bowel disease broadly, which is made up of Crohn's disease and ulcerative colitis. These are chronic conditions that cause chronic inflammation of the bowel. Crohn's disease in particular can affect any part of the bowel from end to end. And it not only can affect any part of the bowel, it's also transmural inflammation, meaning the inflammation can go through and through from the inner lining of the bowel all the way to the outer lining of the bowel, and that can lead to some of the complications that we see. These are common diseases. They seem to be becoming more common, along with pretty much all other immune-mediated and autoimmune diseases. This was a recent study where they looked at a couple of different large administrative claims databases and found similar results in both, so they aggregated them. But the findings have been seen in other sources as well. We don't have national data in the United States, but when you look at countries that do, like Denmark, Sweden, places like that, they actually come up with remarkably similar prevalence data. Yes?
Are these data from U.S. or elsewhere?
These are U.S. administrative claims data, which means they're not truly representative data, but they're recent. This is from the U.S. and this actually I thought about putting a couple more slides in on this, but didn't for time and space. But you actually find similar data, province-wide data in Canada, national data from Denmark, that the incidence is rising. This is prevalence data, but the incidence is rising, and it's rising similarly in other countries as well. Good question. Well, the incidence part is brand new disease. How much of that is improved detection versus an actual change in incidence? It appears to be an actual change in incidence, because when you look in countries that have had national data, consistent data collection over the course of decades, you see the same patterns. Not so in the developing countries, but we do see increased incidence, and this has been seen in other diseases as well. It's hard to really figure out how much of this is improved detection, how much of this is improved coding versus a true increase in incidence. But even in, like I was saying, local populations where you actually capture everybody, it looks like it actually is an increased incidence. So this is inflammatory bowel disease, which includes both ulcerative colitis and Crohn's disease. This is adults, and the prevalence looks like it's about 0.5% at this point. Excuse me. And this is the pediatric data. The peak age of onset is in the teens and 20s, and so within the pediatric age range, we'd expect in the older kids to see the higher numbers. Now, if I was only going to look at the University of Michigan data, I would say, whoa, it's a lot more than this. But I think a lot of that is referral bias. A lot of that is capacity, that as we grow, we can see more kids. But if you look at the state of Michigan, the total numbers appear to be increasing, and where they're going and who sees them and how they're identified, how they're diagnosed is a big question that I'd really like to dig into a bit more. So a little bit more about the diseases themselves. Since Crohn's disease can cause inflammation in any part of the bowel from end to end, the symptoms people experience are widely different. If you look in the textbooks, it says abdominal pain, diarrhea, blood. That's only these kids. About a third of kids with Crohn's disease have inflammation in the colon, and they get the bloody diarrhea. But if you have inflammation further up in the bowel, and the further up you go into the small intestine, there's very few nerves in there, and then you can actually have lots of inflammation and have very, very few symptoms, or the symptoms might be very vague. You might have bloating, some abdominal pain. You know, everybody has abdominal pain. Some of these kids look well, feel well, but just don't gain weight, don't grow. So some of them are misdiagnosed as having eating disorders. Some of them have arthralgias or arthritis and get sent to rheumatology thinking that they have juvenile arthritis. These kids in particular get missed, and that leads to a lot of delay in diagnosis, which I'm going to get to in a moment. But the types of symptoms that people have are quite different depending where in the bowel the disease is located. Oh, there you go. There's the symptoms. Yes, I could use this thing. Okay, so since it's a chronic inflammatory condition, a chronic smoldering condition, chronic inflammation leads to tissue damage, which leads to attempted tissue repair. Chronic inflammation gets replaced over time by collagen, by scar tissue, which leads to stricturing, narrowing of the bowel, blockages of the bowel, leads to surgery, removing the scarred piece of bowel. And without treatment, this is a relentless progressive process that just gets worse and worse. And this is a score that somebody invented to try to sort of quantify how much damage to the bowel there is. The score itself isn't so important. It just, I think, illustrates the case that you have maybe bouts of inflammation, but over time the damage that gets done isn't really reversible, and that's what leads to many of the complications. And so going back in history, if we look at rates of surgery, rates of complication, rates of morbidity of people with inflammatory bowel disease, with Crohn's disease in particular, historically, especially back in time before we had some of the newer drugs that we have today, there was a lot of morbidity. So this is a study that was done looking at patients in the UK in the 1980s and 90s. Total parenteral nutrition, or hyperalimentation, it's sometimes called. This is IV nutrition. This is when your gut doesn't work and you give nutrition via IV. Back then, back in the 80s and 90s, the Crohn's disease was the #1 reason for receiving IV nutrition. And this was because you get a stricture, the surgeons remove that piece of bowel, it comes back. You get another stricture, you have another surgery, another stricture, another surgery. And even today in adults, well, I guess I'll keep going. So, and then by the 90s in the United States, it was the #2 reason for TPN. And even today in adults, about a third of all adults who have short gut syndrome, which is where you don't have enough intestine left, have Crohn's disease. This is, the main causes of this are trauma, cancer, and Crohn's disease in adults. And these are the people who had Crohn's disease in the era before our current medications, or at least I'd like to think that we're doing better. This is a study out of Sweden where they do have national data, where they've looked at mortality, and they looked at reasons for mortality in childhood onset versus adult onset inflammatory bowel disease. So this is both Crohn's disease and colitis. And what they found was that people who had Crohn's disease onset during childhood compared to essentially age-matched people who had Crohn's disease that didn't start until adulthood had a higher mortality rate. And this is just published now. So this is data looking back over the course of the last 40 years. And the big reasons that they found that were significantly associated with mortality were diseases of the circulatory system. Now, this lumps together a lot of things, including clots, thromboembolic events, ischemia, and other things. And vascular problems do exist related to Crohn's disease, and Sarah and I have been talking about collaborating on a little project related to this. Most of these are infections and cancers. So I bring this up just to show that these are highly morbid diseases, and being a sub specialist, I guess, we get lost in our own world and think that's the only thing that's out there. But this actually affects a lot of kids. And the thrombotic complications, increased risk of strokes and pulmonary embolism, deep vein thrombosis, and we do see these in kids, which is usually thought of as a problem of adults.
You see deep vein thrombosis in kids?
Oh yeah, yeah. And the most common place in GI, outside of not specific to IBD, the most common place, or maybe just not GI, the most common place in pediatrics where we see those is in people with central lines. The vein that line is in gets infected. I mean, gets clotted. But kids with inflammatory bowel disease, particularly bowel disease of the colon, so ulcerative colitis or Crohn's disease involving the colon, the rate of deep vein thrombosis actually is quite high. And I saw a kid in clinic last week who is now 10 years old. He was originally diagnosed when he was 4, and soon after diagnosis, he had a stroke. He had a clot. Thankfully, he's recovered from that. But this happens. You don't think of it in pediatrics, and maybe that's part of the problem. We should think of it more. We have protocols for anticoagulant deep vein thrombosis prophylaxis in kids admitted to the hospital. But part of what they found in some of these studies is that risk doesn't go away the day you go home from the hospital. So we should actually probably do better about treating them to prevent clots even after they go home. So this is the history of the drugs we have. We have a lot of drugs now compared to what we did just a few years ago. It's nice to have treatment options, but that hasn't gotten rid of the problem. If you look over time at the complications from Crohn's disease, this is the rising use of infliximab. This is the rising use of adalimumab. These are the two main anti-tumor necrosis factor drugs that we use. And this is the rate of bowel resection. So hopefully we should actually be seeing fewer people developing short gut syndrome over the years as time goes by, and we treat people better and prevent the need for these surgeries. I want to point out this, because I'm going to focus on this in a little bit. These blocks together all represent fistula. It's weird how they made this graph. But if you look at this is inpatient and outpatient data, and if you look at the rates, this is per 1,000. So this is like way less than 1% they're documenting here. It's hard to tell if this is changing or not. And that's one of the things I'm going to talk about in a moment. But I just want to point this out because we'll come back to that. This is a study we did when Kelly Sandberg was a fellow here, looking at hospitalization. And this is using the national inpatient sample. And it looks like the hospitalization rate for children with inflammatory bowel disease has been increasing over the years. But if you look at the rates of increase of hospitalizations that include surgery, that's increasing less. So it may be that we're shifting the types of problems from surgical bowel resections to other types of complications, severe disease, infections, thromboembolic events. Whatever it is, we're still seeing a lot of problems with these kids. So, all right, now the specific to the complications. So Crohn's disease, I was saying, causes inflammation. Inflammation can cause narrowing the bowel. Narrowing the bowel in the presence of inflammation can make the stuff that's in the bowel, the partially digested stuff or stool, it takes the path of least resistance, and it can poke a hole right in the bowel. And the hole in the bowel is called a fistula, and that's supposed to represent an abscess. This was a painting by Dr. Netter that showed these are ulcers. Ulcers are craters, essentially. They're like divots or potholes in the lining of the bowel. And when you have severe inflammation, those ulcers can actually go through and through and worm their way through to whatever structure is next to it. And that's called a fistula. And this is a fistula from bowel to bowel. This is a fistula from bowel to bladder. They can go to whatever structure is next to them. The most common place for fistulas is in the rectum. This is the rectum. This is the outside world. These are ulcers, and this shows how that hole, that fistula, goes right through. This is the sphincter muscle, which very commonly happens and can sometimes lead to damage of that muscle. This was a really nice study. It was actually population-based in Wisconsin, where they looked at the types of fistulas that and this was all ages, very few kids, but all ages that they captured, and found that about half of all patients who had fistulas, this is not half of all patients, of people who had fistulas, half of them were perianal, 9% rectovaginal, so from the rectum to the vagina, which, as you can imagine, can cause a lot of problems and discomfort. Enteroenteric is about a quarter of them, and then all kinds of other complications. But these together all represent perianal or pelvic fistulas, and that's about 2/3 of all people with fistulas combined. So fistulas can cause lots of complications, lots of discomfort, have a major impact on quality of life. They can lead to the need for surgeries, lead to expensive medications, lead to the need for an ostomy, which is where stool goes into a bag instead of pooping into the toilet. So when I started working in this field, I started seeing these kids with fistulas, and I started seeing way more of them than what was reported in the literature. And then I started pulling and reading some of these papers, and the cost of care is clearly higher for people who have fistulas, but the statistics that they were quoting it really underrepresented the real prevalence of these complications. So one of the first studies we started working on here was to try and understand the actual frequency of these problems. These were a few of the population-based studies that have been done that showed that these fistulas happen somewhere in the vicinity of a quarter to a third of patients. Each one of these studies had their own sets of limitations, not the least of which was lumping fistulas together with other problems. But when you look at the administrative claims data studies, the rates of fistulas found were in the single digits, very small percents, which made no sense. And I think that leads to a lot of problems with the understanding of the data that we have. So we're part of well, now international collaboration called ImproveCareNow. This is a big quality improvement collaborative. Currently, there's about 110 sites, which includes both the U.S., England, Belgium, and Qatar. At the time when we got the data for this, there were only 91 sites, and it was mostly in the U.S. But this is a prospective quality improvement collaborative where we collect data on patients prospectively, and then we use that with quality improvement methods to improve care. But we have this huge database. So one of the first studies I did with this, with the help of Kevin and others, was to look into this database to try and figure out what's the actual incidence of these perianal fistula complications in kids with Crohn's disease. And this was funded by one of the pediatric department grants, which was very helpful. So at the time, there were about 11,000 kids with inflammatory bowel disease in this registry. Now it's over 30,000. The group has grown so much. And when we cleaned up the data, focused only on Crohn's disease, where we had consistent data and weren't missing the pieces that we needed, including enrollment dates and things like that. This is what we found. Out of the 6,000 or so kids that were left in the study, we found that the incidence of perianal complications of Crohn's disease was really high, and by 5 years after diagnosis, more than a quarter of kids with Crohn's disease had already developed these complications. That made more sense to me as a clinician because that's what I was seeing in practice. Like this happens all the time. So then the question came, okay, what are we going to do about this? Or can we do anything about this? Can we figure out who's at risk for developing fistulas? Can we prevent them? Can we do a better job of treating them so that they don't develop into more complicated problems? Prevent people from needing surgery, prevent people from needing ostomies. It turns out that figuring out who's at risk of developing fistulas is really complicated, more complicated than I realized. And it's both a problem of poor quality data, but also a problem of not really understanding the pathophysiology, not really having the tools to answer the question. But one of the first things that we found in that same study, we looked at the incidence of fistulas, perianal fistulas in Crohn's disease. We had race data, some very crude insurance data, some geographic location data, and we found that non-white patients had a higher incidence of perianal fistulas than white patients did. About 30, oops, sorry. Where did my little hazard ratio thing go? All right, it was about 30% higher, something in that ballpark. This is just a description of what we see. This doesn't tell us why. I don't know if this is biologic. I don't know if this is differential treatment. I don't know if this is access to care. There's a lot of different things this could be, and it might be a combination of multiple things. I worked on several projects to try and see, are there patient characteristics or features that can tell us who's at risk that we might be able to treat more aggressively and prevent these things from happening. This is not important so much for this audience, but one of the hallmark features of Crohn's disease in the biopsies are these things called granulomas. Even though it's the hallmark feature, it's only found in about 40 or 50% of people with Crohn's. Lots of people have Crohn's without that. And there's been lots of old, long-standing theories that this plays a role in more complicated disease. There's only been a few papers out there, and their studies are really poorly done. I can talk about some of the limitations of those studies. So we decided in our single institution to look at this and pulled the original biopsies at the time of diagnosis, had the pathologist who was blinded to the outcomes and history reread the biopsies to see were there or were there not granulomas. And we found actually, yes, those presence of granulomas in biopsies was associated with a more than doubling of the incidence of subsequent fistula development. And this is a really small single institution study, so I'm reluctant to get too excited about this, but I am excited about this because one of the things we found is if you look at people with granulomas who were treated with anti-tumor necrosis factor medications like infliximab or adalimumab, compared to those with granulomas who are not, there's a huge difference in the rate of subsequent perianal fistula development. So perhaps not only are there hints about who's at risk, but maybe it's preventable. It's hard to know anything from a small study like this, but it's at least a hint. The other thing we looked at, and there's a study that had shown that people who have skin tags or hemorrhoids or fissures or other kinds of things in their bottom at the time of diagnosis are at a higher risk of developing fistulas later on. It's a nice study that was published, but it was unfortunately they didn't do any imaging to make sure there's no fistulas already there, which was a huge problem with that particular study. So we essentially redid the study with our own patients and had the radiologist, again blinded to the history, look at the original MRIs and CT scans and look, was there a hint of fistula or is it poor quality imaging and we can't tell, so we exclude those patients. And here we also found that there was a difference. Even in people who did not yet have fistula, if there was a skin tag, they were actually at an increased risk of later developing, which kind of makes sense from at least how we think of these things developing. But then the question is, of course, can we do something about that? Yeah, can we prevent fistula? So this is that group that had the skin tags who were at a higher risk of fistula than the other group. So just focus, I'm going to show you the next graph, but that's only using these patients, not using those patients. And this is what we find. If you're treated with these anti-TNF medications compared to people who are not treated with these anti-TNF medications, there's a big difference in outcomes. Now, there's lots of confounding by indication here. It's a small single center study. There's a lot of potential problems with this study, but there's nothing else out there that's ever looked at preventing these things. So this paper is now under review at Clinical Gastro. I actually just got the comments back yesterday, and they sound like they're interested. They want us to fix up a couple of things, so hopefully. Which is one of the bigger journals, and they never publish single institution small pediatric studies, so I consider that encouraging. We'll see. All right, but back to remember this slide from earlier showing how different the statistics are from claims versus population studies. So we got a grant from the Blue Cross Blue Shield Foundation of Michigan Foundation to develop a better method for identifying perianal fistulas through administrative claims data. And we basically want to look at other billing code data around the event to see if combinations of claims could be more reliable than just that single billing code for fistula. Because in our old paper billing codes before we had Epic, fistula wasn't even one of the options you could check. I mean, there's lots of reasons it might not be used very, very well. So we identified patients through Medicaid here at University of Michigan. We had people abstract charts who were blinded to the other study information, and then we compared that to administrative claims and had a whole series of candidate definitions that we then compared against what was actually in the medical record using that as the gold standard. And this is what we found. This is the original reference case definition of just this one billing code 565.1 in ICD-9. And you can see that the sensitivity was pretty lousy, only about 50% sensitivity. When we looked at all of our candidate definitions, which is what all of these different symbols represent, the best performing definition was much better than the original, with a sensitivity of 78%, without sacrificing very much of the specificity. This was painful to get published. Many of you have heard the stories about all the journals that we submitted this to and all of the delay and the pushback, and like nobody thinks it's their subject matter. Eventually, plus one, thankfully, after a very, very long road, accepted it. So this is thanks to Kevin and everybody's help and perseverance. We got this thing published. So this is a methods paper that now finally we can use to move forward and do a whole bunch of other studies. So
What was the definition?
the definition was very simple. It was either that claim for perianal fistula 565 point whatever it was, or a procedure on a fistula, like putting a ceton in, or fistulotomy, or fistulectomy, or one of those things. That was actually the best definition. It was simple. There are a couple of other definitions. There was one that actually was slightly better that included medications, which is one of the original things that we were looking at. The problem with that is we can't then study medications if we use that definition. So this was actually the second best definition. It was really simple, and it kind of makes sense. It's either there's a fistula or a fistula procedure.
And we've seen this in other work, series and kind of work with the sickle cell. And what you do when you have these definitions is you start piling on other criteria, and so you can improve the specificity, meaning you get rid of the junk, but it's just little tiny incremental gains, and you lose giant chunks of sensitivity by raising the bar. And so it's actually really a good news story, not only in the IBD world, but also in some of Sarah's sickle cell world, is that, simple measures oftentimes are the best.
Yeah. And this one has face validity. It's a measure that actually makes sense, as opposed to some of the convoluted ones we were trying. Like, if you have imaging before you have this medicine, forget that. The time sequence ones.
Form.
Talk to me tomorrow. No, we actually have a meeting where we have that. We've been working on it for a long time. I have a meeting tomorrow morning with my division to unveil our new smart form, and then we're going to start pilot testing it because I think it's ready to go. One of the problems with studying these things, aside from kids not wanting anyone to look at their butt, doctors not wanting to look at anybody's butt, but also the billing code and the billing code not being specific. The other problem with studying these things is the data that we have are lousy. The ImproveCareNow data, that first study that I showed with the increasing incidence in children, the question in the data collection form asks, is there an indolent, the options are normal or indolent fistula or non-inflamed skin tag. That's option 1. Number 2, draining fistula, painful fistula, or inflamed skin tag. Option 3, lots of drainage. It's like normal is also includes fistula. There's no normal option in there. It's a mess. So the trick behind that study, which actually made it possible, is we look longitudinally per patient at change in that phenotype, along with the physical exam findings. We required actually changes in both to corroborate it. And That took a lot of back and forth to get to something that well, we all felt comfortable with, and people at ImproveCareNow agreed with, and of course the reviewers agreed with, made sense because, and that's why the title, I was very careful with the wording of the title. It doesn't say perianal fistula, it says perianal disease, because in that paper we still couldn't be certain that some of the physicians weren't coding skin tags as fistulas. And even in our society guidelines, the language is ambiguous. It's crazy. Hopefully this is all going to get better soon.
This is all ICD-9.
This is ICD-9. The ImproveCareNow one was actually prospective data collection in a registry.
Sorry. Claims-based.
Correct.
So you do not have ICD-9.
We do not yet. However,
is it better or worse?
I don't know.
Like, did the specificity of the codes get worse? Sometimes it usually gets better.
Well, there's more of them. I don't know what people do with them. So if you look at our Epic and how if you look at our Epic and how it works when you do the problem list and it links it up to the billing codes, when you say perianal fistula, it gives you a whole list of codes, and the language attached to the codes, there's a lot of different options attached to the same code. There's another code with some other language, and there's overlap. So I don't actually know how people are using the things. So even though this study was based on ICD-9, the subsequent study I'm going to show you in a moment, we used both ICD-9 and ICD-10 without any further validation studies. So that's what this is. We got an ART-21 to then look, using administrative claims, can early medical therapies prevent fistulas? Because, I mean, these things are terrible complications, as I showed you before. And maybe this is the general pediatrician remaining in me, is that it would be better to prevent these things than to try and treat them, because the treatments are terrible. It's not that the medications are terrible, it's that they're ineffective, and these things come back ineffective. So we used Optum Insight data, identified patients with Crohn's disease with a run-in time pre-diagnosis, so we could identify the time of the incident diagnosis. And then we looked at patterns of medication use to see if that was associated with either a prevention or delay in the subsequent incidence of perianal fistulas. We did a propensity score matched analysis to try and account for some of the unmeasured bias by indication, from unmeasured variables. What we were talking about when we walked in the room, interestingly, the reviewers thought that we should, the comment was very interesting. This is not a rare event. They said propensity score matched analyses was intended for rare events. We should just do multivariate analysis. We should just do multivariate analysis. So we talked about this. We disagreed. This is the more conservative approach. We decided we'll just put that in as a secondary analysis. We're going to try, hopefully, resubmit this in the next few days.
I would be shocked if it actually mattered whether you ran as a multivariate analysis versus a propensity.
It shouldn't.
I've never found that to matter.
It shouldn't.
There's a bunch of BS about how propensity score matching actually solves the problem of unmeasured conduct. Total BS. Do not believe it.
Well, it doesn't solve the problem. It might mitigate it a little bit. Either way,
it can make it worse.
If
it's actually empirical data that it actually.
So now we're going to have both sets of analyses, and I expect that they'll agree with each other. I don't know. We'll find out. So basically what we found in this study was that SST is steroid-sparing therapy. So this is anti-tumor necrosis factor medications. This is immunomodulators like azathioprine or methotrexate. So the patients who received steroid-sparing therapy were less likely, this is time in days, so a year, 2 years, from diagnosis of Crohn's disease, not from diagnosis of perianal pain. And this is the proportion who are free from perianal fistula complications at this point in time. And what we found is that patients who received those medicines early on in the course of their disease were less likely to subsequently go on to develop perianal fistulas, which, as a clinician, it just makes sense. You treat the disease, the outcomes are better, but this has never been studied before. And the medical world, at least the GI world, is very focused on drug trials and very focused on other things. So it would be nice to have this out there. All right, so this isn't actually the first data to show prevention, but it's the first data to specifically look at this. This was a study from Olmsted County, Minnesota, where they looking at adults with Crohn's disease, and they found that what are the predictors of having complications, fistula, strictures? One of the predictors was being treated with mesalamine or sulfasalazine. These are old medicines that are not immune suppressive, and there's lots of evidence that they don't work for Crohn's, but it continues to amaze me, whether I look at the ImproveCareNow data or the national claims data, how many patients are on these drugs and are not on what we consider standard of therapy drugs. And they found that using these drugs was associated with a higher risk of complications. And I think that's a surrogate for not using other drugs.
Do you think that's due to insurance status? Or something that's an older one?
I think that so the question was, is that insurance status that does that? I think that's a very definite possibility. The bottom line is we don't know. So the reasons I think are, number one, insurance status definitely could do this. And there's this thing they call step therapy where they require you to fail these drugs before moving on to other drugs, which there's society guidelines and lots of evidence to show that that's really inappropriate, but insurance companies push it anyway. There's also fear of these drugs. Nobody wants to put their kid on an immune suppressing drug. And there are a lot of physicians, there are a lot of parents who don't want to use the effective drugs. There are physicians who also think, well, let's try this first. If it works, great. The problem is there might be a time window of preventing those complications, and trying this first may actually set you up for failure. The other problem is the way we measure success in a lot of studies, and the way physicians often think about success is the kid feeling better. And symptoms are lousy predictors. If you compare patient symptoms and the disease activity indices that are symptom-based to endoscopic findings or MRI findings, there's almost no connection. There's people with terrible symptoms who have zero inflammation. There are people with terrible inflammation who have zero symptoms. Using symptoms to guide therapy doesn't work, but that's what people often do. So I don't know if it's fear of the drugs. I don't know if it's misunderstanding of the disease. I don't know if it's insurance company. I don't know if it's access to care. There's lots of reasons this could be, and I suspect it's actually all of those. The IBDQ, the IBD quality of life measure, is one of the standard measures. There's some promise measures, and there's now a new IBD specific promise measure, but they all suffer from the same problem. They're symptom-based. And the problem is, so in the very beginning I said inflammatory bowel disease is not irritable bowel syndrome. Irritable bowel syndrome is very, very common, causes lots of pain, but there's no inflammation involved in it. It might be, there's lots of reasons that might be. It might be a motility problem of how the bowel moves. It might be damage to the nerves of the bowel. But there's a substantial proportion of people with inflammatory bowel disease who also have irritable bowel syndrome. Maybe the inflammation of the bowel damaged the nerves, which left them with the irritable bowel. The two commonly coexist, and those measures really measure the irritable bowel more than the inflammation piece of it. So we don't have, I put more stuff in here than I knew we had time for, but one of the things I could show you at the end is the gold standard for real outcome measures, what the FDA is now requiring is endoscopic or colonoscopic assessment. You need improvement there. There's problems with that too. But the problem is the disease activity index from colonoscopy, the simple endoscopic score of Crohn's disease, the SESCD, is really convoluted. It is used for research. It's what the FDA requires, but no clinician uses it. Even if they scope somebody, it's so complicated to fill the thing out, people just simply don't. So we came up with a new score. It's really simple Likert score, normal, minimal, mild, moderate, severe of the colon, of the ileum. We did a prospective study where we recruited patients, the kids with Crohn's disease did videos and had central readers score the old score and score the new score. And it performs as it should because it was designed to correlate. It correlates beautifully with good intra-rater reliability, and also the central readers said this is way easier. So hopefully we'll now have that once it's finally published. It's under review, so hopefully it'll get out there soon. But now we'll have one tool to actually measure some objective outcomes of disease activity. There's lots of limitations, like there's lots of people who don't do follow-up colonoscopies. You can't do the score without it. I have a slide at the very end about that score, but part of the problem is the disease activity indices are lousy, and people routinely don't record colonoscopy information. There's an MRI score, which is probably really good, but there's a cost involved in doing serial MRI scans, as there is with doing serial colonoscopy. So we don't actually have really good outcome measures, which gets me back to this whole perianal thing in the first place. The ImproveCareNow network was collecting those variables from the very beginning, but nobody was looking at them. And part of why I chose that to look at is not that I have a particular interest in this, except that it's a miserable outcome that would be nice to prevent. But the other reason is it's measurable. It's there. There's no fancy tools you need. So I'm hoping that this is an area that we, in the end, won't have to haggle over what's the outcome measure. It's either there or it's not, and then maybe we can actually prevent it. Sure. No, yeah, they could. There's a subgroup that's working on the promise measure that they want to include it. There's a lot of sites that still collect data manually, and there's a lot of pushback against adding new measures because of the burden of collection of data. The one question, they ask 3 questions at the top of the form. One is, how's your quality of life? I forget the exact wording of it. Quality of life in the last week. Yeah, like normal, poor. Yeah, and then there's a very high level questions about quality of life, abdominal pain, and there's a third one. There's no validated scale or anything, and I don't know who fills that out. Is it the patient? Is it the parent? Is it the physician? Is it the medical assistant checking them in? Each institution is probably doing it differently. There's a lot of problems there. But the leadership is changing. It's not a leadership issue. It's a lot of it's been an infrastructure issue. Yeah, and a lot more sites are going to data collection through smart forms and things like that. They have a relationship with Epic and Cerner creating data collection forms. So my hope is that it'll become easier to add new data elements going forward. At this moment, it's been painfully slow to add anything. Even though our group agreed on fixing the perianal measure, I think 3 years ago, it still hasn't happened. But our group, meaning ImproveCareNow, the clinical committee, but us at U of M, our new form is going to collect that information, which will populate the ImproveCareNow form, but also locally we'll now have the data. I think. I don't actually know what a smart data element is. I know that the way.
Kind of like a holder might answer a question for questionnaire, but then it'll like have the same meaning. Like it sort of takes even if you enter it in multiple different ways, Epic and they have different X and the X means X. Does that make any sense?
I can ask the question because we're meeting tomorrow morning. What I understand is what's entered by the clinician in the smart form gets stored locally in discrete variables, and that can then be exported to ImproveCareNow or used locally, both to populate progress notes and for our own local research purposes. But I don't know what form that's in.
So there's this thing called Cosmos, which is
excuse me.
Epic is basically kind of establishing their own repository of all Epic, right? And so there's 10 centers that have signed on, and there's 20 more that are
Are we one of them?
We have not yet. Yeah, well, we're slow because we don't have sites or dice are up. But what's interesting is that Smart Data Elements, I think, is going to be the engine by which could add new sort of elements beyond the standard stuff like meds, lab utilization, right? Mm-hmm. So if ImproveCareNow had smart data elements and everyone was using those in the same way the rest of the workflow, in the end, Fistula can mean fistula in the Cosmos as opposed to. That
would be very nice.
Yeah.
Currently, even for the sites that have direct data transfer, medications and labs are still manual. Even
Oh, it is?
yeah, there's we can talk later. There's a lot that needs to be done to improve that. It's got tremendous potential. It's just a slow large ship to steer. So the little time we have left, I was going to show some of the other data from other studies on prevention. But the big thing that I've been interested in focusing on is why the delay in therapy. If we have evidence to show that early treatment improves outcomes, what's going on? And this gets back to the question about, like, what is this? Is this insurance delay? Well, there you go. Lots of possible reasons that people aren't treating the kids. Everything from insurance to access to care to fear of drugs. There's more. There's lots of reasons. So I think part of what leads to the delay is the non-specific symptoms. And when you have non-specific symptoms, it confuses people. And people think, the symptoms are better, you're better. About 8 to 10% of kids have no symptoms. Their disease predominantly manifests itself in ways that don't cause symptoms. Oh yeah, abdominal pain is not a thing. I mean, everybody gets abdominal pain. You've all seen this before. This is about the patients who referred from their primary care doc to the surgeons because of perianal lesions. And we found that about a quarter of patients have perianal lesions at the time of diagnosis, and lots of them are sent to the surgeons, 20% of them, instead of sending them to GI. And these are things that, if you look in up to date, if you look in the clinical recommendations for hemorrhoids for adults, they say if they get symptomatic, cut them off. That's appropriate for adults with hemorrhoids. Adults get hemorrhoids. It's actually a very, very common problem. Kids don't get hemorrhoids. And when the pediatrician never got training on to know what they're looking at, they see something, they look in up to date, it says, oh, send them to the surgeon, they do. 20% of them. Problem is if the surgeon cuts off a skin tag, that leads to worse outcomes. Most fistulas, many of them at least, will heal with medical therapy alone and don't need surgeons. So part of this is maybe educating the pediatricians or the referral base. Part of this might be about the fear of medications. So we developed this tool to try and just show the risk, because this is people's perception of the risk of cancer from the drugs that we use. Risk of lymphoma, risk of colon cancer. This risk is actually way down here, but this is people's perceptions as we survey parents about what they think about the drugs that we use. And I worked with Brian Zickman-Fisher to develop some graphic tools to try and display the risks of the disease with different medications and the risks of lymphoma with different medications. Because we have lots of pamphlets that talk about the risks of drugs, but actually comparing them side by side along with the risk of the disease was missing. So we developed this. We made a little video so it has a consistent narration of the same wording for everybody. And then half the families saw the video, half the families didn't. And no surprise, the people who got the educational material had a much better perception, much more realistic perception of the risks of cancer from these drugs. This is still higher than the real risk, but it's still better than this. And actually, colon cancer is caused by the disease, not the drugs. And not treating the disease makes colon cancer worse. So this is also oddly backwards. But regardless, this is finally now accepted in press, and the video we have online so that we can show it to families. So I'm hoping this will also help with some of those perceptions. This took so long to get published that it's now out of date. We have to add a couple of the new drugs to it, but regardless, it's nice to finally have something like this available. Anyway, there's a lot I'd like to do to try and figure out diagnostic delay. We need to do more than just administrative claims data. Some of what we need to do is figure out the pathway to diagnosis, how many kids are referred to the wrong specialist first. Some of this is the delay in the referral. Some of this is in insurance. So we, I don't know, I have time to get through all of this, but some of it is also about decision making. So we need to have a qualitative piece where you interview families to figure out, like, how was this decision made? Did you decide not to use these drugs because you were afraid of them? Because your doc said, nah, it's not so bad, you don't need it? Did you not use these drugs because the insurance didn't let you? Did you not use these drugs because you never even heard about them? I mean, there's a lot of possibilities. So one of the studies we want to do is, one of the studies I want to do is both looking at the pathway to diagnosis, but also looking at the qualitative piece of interviewing families about how the treatment was made. Anyway, we're essentially out of time. And then, does delay in diagnosis lead to sicker patients? Does it lead to different medication selection? I suspect, and this is another study that I would like to do, is insurance companies put up all these roadblocks to using these expensive medications because, of course, they're expensive medications they don't want to pay for. But does that lead to worse disease outcomes and then increased cost in the end? I think if you look at the lifespan of a patient, the answer is going to be yes. But I don't know if you look at the lifespan of enrollment in an insurance company, if it makes sense to, if it still will change their calculus.
You guys document when the painful process of viral like this?
No, we are terrible at documenting. I tried to go back and look at it, and because I wanted to do a little local retrospective look at insurance delay. And even though we spend time writing letters, the nurses spend time, we all spend time on the phones, a lot of it wasn't documented. In the last couple of years, I've really pushed my group to image everything, document everything, but even still, a lot of it doesn't get documented.
We're going to do it for diabetes, but
How are you going to do it?
we're going to create a budget. Yeah.
All right.
And we have like our exclusive, like their only job in the world is our authorization, right? So they're going to do it.
Okay. Can we talk?
Yeah, we can talk.
Because I want to do the same thing, because this isn't captured anywhere.
Yeah.
There's nothing in claims that'll, the administrative claims data won't answer the question of when was the prescription written versus when was it dispensed. They don't have that. If we don't capture it. Yeah?
Yeah.
Yeah. I would
Wait, but we're talking about like all of the stuff that had to happen.
Right.
Well, that's what I'm saying. It's like I feel like that is like that's a function of the system,
It's a, yeah.
right? I mean, there's a little bit of
It's a
like
function of the
function
system,
of the system, yeah.
and it's a function of the system that the insurance companies take advantage of.
Right,
It's a war of
but
attrition.
it's also a function of the system that
Right.
we have that like we're so ineffective at organizing.
Right, and the insurance companies
Like,
benefit.
we lose our prior auth people, and then they're like, "Oh no, we're not going to replace them." Like, where do you think these people are getting their supplies? Like,
Right.
you know, and then it takes them like 6 months to rehire someone, and you're like, you could have.
No,
Yeah.
no, I don't think it's unique.
Right.
But it's a war of attrition. So if these drugs cost $10,000 a month, or whatever number you want to pick, if that prior authorization process delayed, even if the drug's approved, if it delayed them by 2 months before getting started, the insurance company saved $20,000 per patient. Even if they delay a week, they make money off of it.
Well, at that moment, but then you can look at like the outcomes for surgery and everything else
Right.
downstream, which is really what you want.
Which I would like
There's
to-
a comparative effectiveness.
Probably not.
Unless,
It's like you're buying health, you're improving health outcomes, but for these really expensive drugs, it's probably not.
unless the health out.
Threshold.
What's that?
We should not expect anything to be costly.
No, of course
No.
not. I mean, that's my
We
point.
should
But I mean,
expect something to be
even
cost
things like
effective, but not costly.
But if the outcomes are not 5 years down the road, if the outcomes are 6 months down the road, then it could happen in the window of when the insurance company would potentially care about it. And then I think that's when you can make the argument that by your delaying, you've actually increased costs. I don't know that we would find it when we look at it, but the incidence, most of the fistulas happen in the first year.
So there's some interest as you were presenting. I think it's really, but there haven't out of the UK because they spend
Right.
so much time thinking because show that actually costs absolutely, but that's not the threshold.
Yeah, we don't need cost saving.
Absolutely.
But if it's both cost effective and it improves quality of life, I mean, even if it doesn't improve quality of life, but if it's cost effective but not cost saving, it's still worth it.
So let me ask you about Medicaid. I want to ask you, does Medicaid throw up as many barriers?
I think not. My experience with Medicaid is that they're more likely to approve things and more likely to approve things with less hoops to jump through, but they are also getting worse. There's more need for the peer-to-peer rather than just submit the record and say the kid needs it.
The reason I ask is because I always thought this. Medicaid is not like public-private insurance because their enrollment span is in fact lifetime.
Right.
So
Right.
It's not like they just have people enrolled for 2 years.
Interesting.
Right?
Yeah,
so if you
true.
take a kid, 3 years old, 5 years old, or something, disease, that is probably going to be
The 10-year outcomes happen in their.
in 10 to 15
Yeah.
years.
But the way,
And then when you have and now with the ACA expansion, state, unless you possibly,
Yeah.
people actually stay in longitudinally. Kind of makes it more, I would think, easier in some
Yeah.
ways. I mean, conditional on the fact that, but they could make those types of
But-
motivation.
But is there anyone with decision-making capacity thinking that way?
I don't know. I doubt it. I mean, I doubt that. What they're probably thinking of is, I am in a state that has a fixed budget that
Right.
I have to balance every year,
Right.
and every time that
And are you going to pay for?
in a 1 year increments to make sure that whatever I spend doesn't crowd out education and everything else
Right.
that could possibly be used, right?
Yeah. And are you going to pay for 1,000 doses of Tamiflu or
No, I
one
don't know.
dose of infliximab?
Right, exactly. That's what
But I mean, the idea being they have
No, I get it.
decisions to make
Yeah.
across a wide range of things, not just this disease.
But there are some Medicaid programs that are much better. Like the guy who runs Medicaid, right? Who's really he's pretty kind of with it, thinking long term. But
even with ACA and expansion, there's still a lot of young adults who are gonna fall out.
some, but I mean,
Where there's better coverage, but
Yeah, the 20
not
to
the same as,
26-year-olds.
Medicare, right? Which is
Yeah.
you're still poor. You don't have a parent who's dependent on. There's much less of a drop off.
Yeah, we looked at that with when Emily Whitfield was here. That was her project, is looking at the change in the insurance of the young adults, before and after ACA, and there was a big improvement. It was not everybody. There was still plenty of uninsured people, but the rate of uninsured went down after implement of the 20 to 26-year-olds after implementation of ACA. It's modifiable if you have policymakers who want to actually look at these outcomes and think about the long term. Anyway, I want to be mindful of people's time, but thank you for
advancing the field.
hoping to.
Amazing.
Thank you. This is just colonoscopy score. Thank you.